Hi, this is Jeannie Yaley, and I would like to welcome you all to workshop number 3, which is Hey Baby, Pregnancy in the Era of Highly Effective Modulator Therapy. We have some wonderful abstracts that are going to be presented today, and plus our last speaker is actually a CF mother's viewpoint, and so that will be a great presentation as well. And this presentation, this group of abstracts are very important because as we look at the report that just came out and looking at the pregnancy of women between 14 and 45 years old, between 2000 and 2015, everything was pretty much a consistent rise. You kind of had about 15 to 20 new moms every year. But then when you go from 2015, you only have around 235 pregnancies. And then in 2020, we bumped up to 619. So obviously modulators are a factor in pregnancies with CF patients. So I just want to let you know our layout for today. What we'll do is after each presentation, you will watch the recording, and then one of the presenters the person who may be on the recording or a coworker of theirs will actually be available for some question and answer for about 5 to 10 minutes, and we'll do some questions, and then we'll go ahead and go to the next speaker. After we are done at the end, just in case there are many questions that may not have been answered, everyone will be joined at the end, and you'll be able to ask more questions of all of the speakers. So without further ado, our first speaker is Tiffany McCrabb from Oklahoma. She is going to talk to us about identifying and addressing the patients at risk for unintended pregnancy and related to the increased fertility with Trikafta.
Welcome to Hey Baby, Pregnancy in the Era of Highly Effective Modulator Therapy. My name is Tiffany McCrabb. I am a nurse practitioner and the interim adult CF program coordinator at the University of Oklahoma. I have no relationships to disclose related to this presentation. Today, I'm going to tell you a little bit about how we identified and addressed patients at risk for unintended pregnancy related to increased fertility with Trikafta or ETI initiation. We were thrilled in the fall of 2019 when the FDA approved Trikafta, Elextez-IVA or ETI, for patients over the age of 12 with at least one copy of Delta 508. By the winter, anecdotal evidence from multiple CF centers were indicating an increase in unintended pregnancies and improved ease of achieving pregnancy for those taking ETI. Our team had noted 1 planned and 3 planned pregnancies in ETI users at our center within the first 4 months after starting therapy. We had some concerns about unintended pregnancy, including the increased health risks for those with lower BMI and lower FEV1. We were concerned about the potential for poor outcomes for both mother and baby. Our CF team took action and planned an educational intervention, utilizing CF Smart reports to identify and prioritize patients, and developed a script to guide our patient education and discussion. Our CF research team ran a report from CF Smart reports for biologically female patients 13 to 15 years of age with at least 1 copy of Delta 508. We deprioritized those known to already be pregnant or postmenopausal. We limited the list to those known to have started ETI, and we sorted it by ascending FEV1 to prioritize those with the lowest lung function. 34 patients were identified during this initial focused education effort. Patients over the age of 18 with the lowest FEV1 were given first priority for the urgent phone calls. Calls were made primarily by the CF program coordinator and the CF clinical pharmacist. The staff prioritized those with known history of high-risk behavior as well. When staff was unable to reach patients by phone, the education occurred at the next clinic visit, either in person or via telemedicine. For those patients underage, the guardians were contacted and educated by phone. For patients under 18 with consent on file to speak directly to the CF Center staff, Those patients were contacted directly and provided education by phone. For those under the age of 18 without consent to speak independently, those patients were educated during the next clinic visit, either in person or via telemedicine. In all, 34 patients were identified and educated during the initial education campaign. No additional unplanned pregnancies were discovered during the intervention period. There has since been one additional pregnancy at our center to the mother who had previously experienced a spontaneous abortion. Our pregnancy outcomes were primarily live births. There was one spontaneous abortion and one termination from these pregnancies. Overall, the educational campaign was well received by the patients and their guardians. It was also effective at informing patients of this perceived increased risk. Since then, contraceptive counseling has now become second nature in our discussions about initiation of highly effective modulators. Family planning is reviewed regularly on follow-up visits, and annual follow-up care with an OBGYN or other women's health provider is encouraged regularly. Thank you so much.
Thank you, Tiffany, for that presentation. And I encourage anyone who has any questions, please enter them into the Slido, and we will then be able to answer any questions that you may have in regards to this presentation. But while I'm waiting on any questions, I did have a few for you. Who actually on your team reached out to these various patients as far as to present all the questions and education?
The primary contact was the program coordinator at the time. That was before I became the program coordinator, but also our clinical pharmacist, who does a lot of the education regarding modulator therapies with our patients. So she had already had a good relationship with patients, discussing modulators and the necessary safety labs, and those kind of discussions had already taken place with these patients. So our CF pharmacist certainly had an established relationship with those patients, but there were certainly some that our program coordinator had a closer relationship with, perhaps because our previous program coordinator was at our center for almost 40 years and had grown up with a lot of these women, had seen them grow up, so had really personal relationships with a lot of these women. So certainly between those two team members, we felt like the women would be comfortable discussing those issues either over the phone or then in person.
Okay. And we do have a question is, what was your retention for parent involvement across the sessions?
It really was primarily just one education session with each patient. And for those underage patients, they actually had a pretty good a good response, and being able to, for those that we didn't have permission to speak with them directly, there's certainly some adolescents that we have permission to speak with directly over the phone who have their own cell phones to reach out to. But for those that we didn't, we definitely addressed it as soon as possible at the next clinic visit. And there were some, I believe, that were even scheduled more quickly to be able to see them in person sooner to go through that necessary discussion about contraception.
Okay. And another question is, was your dietitian involved in all of the education with the patients as well as one of the main people, or?
Absolutely. Our dietitian is very involved, certainly in those patients that were pregnant. By all means, we see those pregnant patients every month, and they are followed very closely by our dietitian. Absolutely.
Okay. And then another question is, what was the lowest FEV1 of the patients that you had reached out to, and how was their pregnancy outcome?
That is a wonderful story that you're going to hear at the end of this session.
All right, so we will wait until our last presenter.
No, not to keep you in suspense. News at 11.
Yes.
I actually don't know off the top of my head the exact number, but it wasn't great. And I think you'll be able to see lots of wonderful photographic evidence of how it turned out.
And then another question from Nihat Madi is, how do different CF centers routinely do teenage pregnancy prevention contraception? They're now more actively referring to adolescent medicine or the primary cares.
That actually question came from our CF director, who is a pediatric pediatric CF person. Yes, I do. It seems like more and more CF centers are referring their adolescents to adolescent medicine. Definitely a discussion that adolescent medicine folks and OBGYNs are more comfortable discussing than some pediatricians. Certainly there's some pediatricians that address women's health concerns regularly and are comfortable having those discussions. But I know at our center, there certainly have been patients that we've referred on to adolescent medicine to discuss those to get into in greater depth in those kind of women's health concerns. Absolutely. And then we use our high-risk maternal fetal medicine team to assist with our CF patients, women who are pregnant.
All right, thank you. And that's the way we do too. We use our high-risk OB to assist with our patients who are sometimes even planning pregnancy or,
Absolutely.
Actually are pregnant, whether it be intended or unintended, actually.
We certainly encourage that discussion at routine women exams long prior to, trying to initiate pregnancy, just so that the plans are in place and the expectations, everyone's aware of what the goals of the time will be, what expectations will be as far as frequency of follow-up and CF visit, frequency of follow-up with the high-risk OB team. Certainly we want everybody to know everything up front. And that was why our biggest concern was surprise pregnancies. And we wanted to prevent surprise pregnancies as much as possible and be sure that everyone is aware of their potential for increased fertility so they could plan accordingly if we're not planning to become pregnant. And for those, a lot of our patients since then are very excited at the idea of a Trikafta baby. So certainly when we have those discussions, initially it was like, oh my goodness, everyone's getting pregnant. But then for a lot of those women who really desired pregnancy, it's a very exciting discussion to have also.
Okay. And I think we have time for one more question before we go on to our next speaker. And the question was, did any women decide to stop Trikafta during their pregnancy? And then what were the outcomes compared to those who actually stayed on Trikafta throughout their pregnancy?
All are continued on Trikafta, to my knowledge. Like I said, this initial education campaign occurred prior to my assuming the interim role as the program coordinator. But to my knowledge, everybody continued on Trikafta through their pregnancy.
Okay. All right. So I think we will go ahead and go to our next presenter. And then if you have any other questions, please feel free, though, to put those in the Slido and just, put them to attention of Tiffany. And so therefore, then at the end, we'll be able to direct those questions, particularly to her, or the rest of the panel may actually answer them as well. So for our next speaker, we have Dr. Montemayor, who's going to talk about the current attitudes and practices with pre-pregnancy anticipatory guidance and pregnancy care in CF. And it's a national survey of actual CF care providers.
Hi, my name is Christina Montemayor, and I'm an assistant professor of medicine at Johns Hopkins University. And I would like to thank the workshop session chairs for allowing me to present the results of our recent study. I have no disclosures relevant to this presentation, and I do have funding through the CF Foundation for this work. So over the years, due to recent advances in CFTR modulator therapies, people with CF are experiencing longer and healthier lives. Since approval of elexacaftor, tezacaftor, ivacaftor in 2019, more women with CF are considering pregnancy ever before. This is due to increased lung function, decreased pulmonary exacerbations, improved nutritional status, and overall improved quality of life. And you can see over the last 20 years, from 2009 to 2019, we're now at currently at 310, and I anticipate that this number has grown and we'll be interested to see what is published in our upcoming annual report. So regarding pregnancy and CF care, there's been recent interest in pregnancy in women with chronic lung disease, and the European Respiratory Society and the Thoracic Society of Australia and New Zealand published a consensus statement on the management of pregnancy in women with airway disease, including CF, in 2020. Most recently, in August of 2021, a multidisciplinary panel of CF clinicians and women with CF published recommendations on pre-pregnancy, intrapartum, and post-pregnancy care for women with CF. However, despite the increasing number of pregnancies in women with CF, there are limited studies evaluating real-world pregnancy care in CF and identifying any differences in the management of pregnancy and pregnancy-related complication in cystic fibrosis remains important to understand. Thus, the objective of our study was to assess current attitudes and practices among CF clinicians regarding pre-pregnancy anticipatory guidance and pregnancy care in CF. We designed and distributed a 28-item anonymous online survey that was sent to CF clinicians, defined as nurse practitioners, physician assistants, as well as physicians, from adult and pediatric CF Foundation accredited care centers in the United States from December 21st, 2020 to January 25th, 2021. So you can see on the left is table 1. I'm providing the provider as well as CF care center demographics. But overall, a total of 93 clinicians completed the survey. 77% of respondents identified as physicians, 14% as nurse practitioners, 5% as physician assistants. 63% identified as female. And you can see that overall 61% of respondents were identified as adult CF clinicians, 22% were pediatric clinicians, and 17% identified as both. Regarding the last 3 columns, years of experience, number of patients managed by CF Care Center, as well as geographic region were pretty diverse. So what did we find? An overall message is to discuss pregnancy early and often. 69% of clinicians discuss pregnancy and family planning during routine clinic visits. 86% of clinicians feel that pregnancy and family planning discussions should start before the age of 21. And of these clinicians, 67% believe these discussions should be initiated prior to age 18. Additionally, we also looked into comfort with continuation of chronic CF therapies. And this is a chart that I've adapted from the 2020 recommendations. And we do have recommendations for use of chronic CF therapies during pregnancy and lactation, inhaled mucolytics, vitamin supplements, as well as pancreatic enzymes have been shown to cause little to no risk to fetal development and have been designated as compatible. Additionally, CFTR modulators had previously been thought to be safe during pregnancy and lactation as well, and at least on this chart are considered to be probably safe. Aside from that, I've adapted a slide that Jennifer Taylor-Kauser presented last year at NACFC regarding outcomes of pregnancy in women with CF taking CFTR modulators, which was from an international study that she was a part of. And overall, in that retrospective study of 61 women with CF, use of CFTR modulators during pregnancy resulted in 2 maternal complications thought to be secondary to CFTR modulator use. CFTR modulator cessation resulted in a clinical decline in 9 women, resulting in reinitiation of therapy and improvement in clinical symptoms. And there were no modulator-related complications that were identified to infants exposed in utero or during breastfeeding. Notably, this study did not include elexacaftor, tezacaftor, ivacaftor, but ongoing studies are currently evaluating that in a prospective component. So overall, on table 2, this is showing respondents' comfort with continuing chronic CF therapies. And we did this by trimester, given the importance that or impact that a trimester may have on medication continuation. And overall, the top 4 columns regarding pancreatic enzymes, hypertonic saline, glucoronase alpha, as well as vitamins, show that the majority of clinicians were comfortable recommending continued use of these medications across all trimesters. Although prior recommendations have suggested that the use of azithromycin during pregnancy and lactation present no risk to low risk to the fetus or infant respectively, you can see here that we found that less than half of clinicians were extremely comfortable continuing azithromycin during pregnancy. Lack of prospective studies on azithromycin use in pregnancy and CF mothers may account for this. Regarding the last 4 rows regarding their CFTR modulators, you can see that overall our results indicate that a higher proportion of clinicians were more comfortable continuing ivacaftor or elexacaftor, tezacaftor, ivacaftor during pregnancy compared to lumacaftor, ivacaftor, or tezacaftor, ivacaftor. We anticipate that this is related to the known efficacy of highly effective modulator therapy, and continuation of therapy provides an increased benefit to mothers with CF. In addition to chronic therapies, we also evaluated practice patterns related to acute treatment of pulmonary exacerbations during pregnancy. As noted, our data shows that clinicians prefer to treat a mild pulmonary exacerbation with oral antibiotics and a more severe pulmonary exacerbation with 2 antibiotics, which aligns with practice patterns in non-pregnant people with CF. Although prior guidelines have not shown sufficient evidence to recommend for or against addition of inhaled therapies for pulmonary exacerbation treatment, we anticipate clinicians were inclined to incorporate inhaled antibiotic therapies during pregnancy, given minimal systemic absorption and minimal risk of inhaled therapies. So you can see under a mild pulmonary exacerbation, 40% wanted to add an inhaled antibiotic. And then for a severe pulmonary exacerbation, we have here, close to 24% thought 1 antibiotic plus an inhaled antibiotic would suffice. Overall, though, future prospective studies evaluating pulmonary exacerbation management during pregnancy would be of great importance to the CF community. We also looked at factors used for IV antibiotics during pregnancy, and overwhelmingly, you can see that nearly 90% of respondents believe that a 10% drop in lung function warranted treatment with IV therapies, followed behind by baseline lung function as well as patient symptoms. And I would think that this is pretty comparable to how and when you would decide to treat a non-pregnant person with CF as well. One of the other things I wanted to highlight from our study was that breastfeeding status is important to assess. And why does that matter? Because breastfeeding impacts the nutritional needs of the mother, and many medications are excreted in breast milk, and clinicians need to know what mothers with CF are taking in order to make informed decisions and recommendations. Notably, 20% of respondents were unaware of breastfeeding status after delivery. And we did find that clinicians would not recommend breastfeeding if the mother's BMI was less than 18. We looked at other factors, or the importance of factors used to recommend against breastfeeding, and overwhelmingly, nearly 60% of clinicians stated that they would not recommend breastfeeding if BMI was less than 18. As you can see here, other factors such as age or a less than 5% drop in lung function were not important factors at play. And although we're presenting some of the first real-world pregnancy care and evaluation of clinicians' attitudes and practices, in CF, we do have some limitations with this study. One, results may not be generalizable to all clinicians in the United States or internationally, as attitudes and experiences may differ. There is a potential for social desirability with the survey questions that were asked. And respondents may represent the most favorable perspective of pregnancy care for women with CF, as they were more inclined to take the survey than people that have less experience managing and treating pregnant women with CF. As far as conclusions and future directions, I think overall, CF clinicians should be initiating discussions surrounding pregnancy early and often. Clinician practices and comfort related to CF-specific aspects of pregnancy care vary. We need to expand peri-pregnancy expertise within the CF community, and future prospective studies are needed to better understand the maternal fetal effects of CF therapies. I'd like to thank you for your time today, and I'd like to thank my primary mentor, Natalie West, as well as advisors Kevin Soder and Kristen Reichert. And I'd like to thank the Women's Health Research Working Group, who were integral in the survey design as well as edits of our manuscript submission. And that includes Natalie West, Tracy Kazmersky, Raksha Jain, Jennifer Taylor-Kauser, as well as Maura Aiken. I'd be happy to answer any questions that you have during our question and answer session, or feel free to email me listed here or reach out on Twitter. Thank you for your time today.
Thank you, Dr. Monamori, for that presentation. It was very interesting. And we do have several questions coming in from the viewers, so therefore I'm just going to go ahead and dive into those. First of all, from Heather Brosius, she asked, do you have any tips on how to initiate the discussions with patients who may have transitioned to adult care and never had a discussion with the PEDS team?
Yeah, thanks, Heather. That's a great question. And I think everyone on the panel could probably approach it a little bit differently, but something that I've become just doing standard of practice is just bringing it up kind of every time I definitely see a new patient. I just ask what their previous experience has been regarding family planning and our reproductive goals, just to get a sense if there have been conversations, and then just kind of like to bring up kind of what their current status is, and just let them know that that's a common theme that I like to talk about during our regular encounters, just so that they know that myself and our center tries to make that a standard of care.
Thank you. Our next question is, what type of contraception do you recommend in the era of Trikafta? And also, do you have a particular like OBGYN who your team collaborates with to send your patients over to?
Yes, and I'll answer the second question first. But okay. We do have a specific regarding our pregnant patients. We do have specific maternal fetal medicine physician within our institution here who sees all of our patients, and we have great collaboration with. Which I think is really important. I didn't get to mention it on this slide, but 82% of respondents mentioned that they do have someone within OBGYN who they refer their patients to. So I think that's a lot of the population, but that I understand that that may not be available to all the centers. And I think right now, kind of in the era of doing a lot of telemedicine and telehealth, I think that we could have some vantage with trying to get some expertise from our FMM colleagues to help with our patients. So I think overall the question is yes, I think that we should be doing that. And I think there's some interventions that we have for the future to try to help make sure that becomes standard for all centers in the United States. And then regarding the question of contraception, that's a good one. And I think I would say anecdotally what I've seen is it's still a bit of a mixture between oral contraceptives, and some patients they'll actually prefer to get IUDs or intrauterine devices for contraceptive methods. And at least my practice is, I am not necessarily prescribing the contraceptives myself, but do have close collaborations with gynecology as well, who I like to kind of send patients to have kind of those discussions with to help pick the best contraceptive method for them. But definitely definitely great questions, and something that we should be talking about based on our first presentation that we just heard today.
And with that answer, you also answered Lauren Kummerlich's asking question, which is when someone's asking about birth control, do you particularly prescribe it or refer to the PCP or the OBGYN? And I can honestly say in our practice, yes, we will actually start with prescribing depending on what they want. And in regards to the other question about what type of contraception, I really think it is whatever they will use. That is one thing as well. What are they comfortable with, and what are they able to do? And so therefore, the patient sort of helps guide that as well with that. But another question we have is, does lung function have any clinical impact on the decision for whether a patient should breastfeed or not?
And I think that's a great question. So I mean, definitely, I know I mentioned BMI, and at least from the respondents, that seemed to be the overarching factor that was most important. But I think that I think BMI and lung function are kind of interplay with each other. So I can't say that there's a specific lung function that people wouldn't have recommended against. I think I talked about specific decline. So probably like a greater than 10% decline in lung function would make me be hesitant, potentially even if we're at a 5%. But overall lung function, I think that's an important question to look at. And, I think probably myself, what I would do personally is take that into account as well, and talk to the breastfeeding mother and closely monitor lung function symptoms and BMI, because I think they all impact caloric needs and et cetera. Yes.
And another question from Carrie Schaefer is, what are the recommendations for when and how often to check vitamin levels during pregnancy?
And I may refer to if anyone else on the panel has any thoughts on that. I mean, I know I check them kind of at the start, annually, and checking the labs annually, and then kind of at the beginning of pregnancy. I haven't routinely checked them more often throughout, but I'm happy to hear if anyone else on the panel has different thoughts about that.
And our center does what you do. We will check them at the beginning, but there's no real, specified guidelines as far as when to check. I think since we're still in, the nuance of pregnancy, even though it's just been within the last year that it's really taken a jump, waiting on those particular pregnancy guidelines to come out and help guide us, actually. Tiffany, you were going to say something?
I would say the same for our center, unless there were abnormalities on the initial vitamins. We don't have a specific time frame, and unless there was something abnormal and we made adjustments, that we might recheck something that was abnormal. But otherwise, beginning of pregnancy for sure, in addition to their annual run.
Okay, and a couple of other. Does anyone else on the panel have any thoughts on as far as with checking vitamin levels? So what we will do, I'm going to, another question is, Shelley Degnan is asking, what were the maternal complications for those who continued on their modulator? Was that asked in the survey, or just if there were complications?
So it wasn't in the specific survey, and I could definitely look that up. I don't remember the two offhand, but I can provide that before the end of the session.
Okay, great. Thank you. Mm-hmm. And then the other question that we have is, can you speak to partnering with genetic testing during family planning? Do you guys refer?
We definitely do. I actually, just a couple of weeks ago, met with someone who they're thinking of, having a family, but 2 years away was kind of her goal when we talked about it. She's overall feeling good, getting married this summer, which she's super excited about. And she thinks that her and her partner want to start planning a family in about, she said 24 to 36 months, so 2 to 3 years, which seems kind of a fair timeline. But her partner has not had genetic testing at this time. So we already started initiating that conversation with her, and just saying, that yes, definitely should be checked and recommended. We kind of give them kind of a standard genetic testing, like a SMART phrase that we give our patients that they can show their partner. And then, obviously we don't necessarily see the partners in CF clinic, but we're also happy to talk to their primary care physician, and we do have genetics available, which we're happy to refer them to if they choose. Some patients aren't necessarily local, kind of within the Baltimore vicinity, so they're happy to kind of go to their primary care physician, and if there's any concerns on their initial testing, then we'll arrange for them to have genetics. But definitely something I think should be talked about, and definitely talked about as early as possible.
Sorry, I agree with you on that. We discuss with our patients genetic testing, because we have had in the case where the actual patient themselves Yes, but then they also needed further genetic testing based upon their spouse. And so therefore there was more that needed to be checked even from their standpoint. So therefore genetic testing and counseling is great. I wanted to go back to the question about the vitamin levels because Suzanne Michelle actually typed in, and she is a registered dietitian, and the plan at their center is if the vitamin levels are available 6 months prior and are within normal, then they will be checked about mid-pregnancy. Again, is how their center does it as well. Just so therefore everyone has another idea of when other centers are, checking the vitamin levels during pregnancy. All right, I think that might be all of the questions that we have for right now. And so therefore, and if you have any other questions, please put them in the chat box. And, and address them. If it is regarding Dr. Monower's talk, then we will actually get those at the end, and just in case you think of something between now and then. But what we will do is we will move on to our next speaker, who is Jessica Corcoran, and she is going to talk about fertility preservation, thematic analysis of interviews with partners of women with cystic fibrosis.
Hello, everyone. And thank you for attending this presentation. My name is Jessica Corcoran, and I'll be presenting this presentation today titled Fertility Preservation, Thematic Analysis of Interviews with Partners of Women with Cystic Fibrosis. I am presenting this presentation today on behalf of my co-authors, Ms. Campbell, Dr. Bray, Dr. Brown, Ms. Woods, and Dr. Ladoris. Dr. Ladoris is the PI of the parent study. We are all assistant and associate professors as well as students at the University of Alabama at Birmingham School of Nursing. I have no relationships to disclose related to this presentation today. Before I get started, I want to acknowledge our funding source. As I mentioned, Dr. Ladoris is the PI of the parent study. It was an R3 study examining fertility and fertility preservation. And it would not be possible, this presentation would not be possible today without our funding from the National Institute of Child Health and Human Development. So a little bit of background. There have been treatment advances among the CF community over the last 20 years, as we all well know. These have increased life expectancies for people living with cystic fibrosis, with more than 50% of the CF population over 18 years of age. And with increased life expectancy, this comes an increase in the ability to attain milestones that were previously unattainable, such as careers, marriage, and families. Since 1999, pregnancy rates among women with cystic fibrosis have more than doubled. And so discussing fertility and fertility preservation options should be initiated early to allow patients and their partners to have all their options informed to them, as well as for them to make well-informed reproductive health decisions. So despite the pivotal role that partners to women with CF have in the decision to pursue parenthood, they are largely neglected as stakeholders in research and clinical care. And because of this, we aim to investigate the knowledge, experiences, preferences, and concerns regarding fertility and fertility preservation discussions among partners to women with CF, to inform future interventions that promote an inclusive family-based reproductive care and collaborative decision-making in CF healthcare. So as I mentioned, the larger purpose of this mixed method study was to examine the knowledge, experiences, preference, and concerns from the perspective of the 3 Ps, and that's patients with cystic fibrosis, providers to women with cystic fibrosis, and partners to women with cystic fibrosis. For the purpose of this presentation today, we're going to focus solely on the partners to women with cystic fibrosis. So, as I mentioned, this was a larger mixed method study, and for the qualitative arm, we conducted interviews with 20 women, 20 providers, and 20 partners. This is the methods and the themes that emerged from the 20 partner interviews. So we conducted semi-structured interviews. They lasted anywhere from half an hour to 90 minutes. They were transcribed verbatim, and they were also audio recorded. And for analysis, We conducted thematic analysis of the transcribed interviews in vivo, and we also conducted line-by-line coding with intercoder agreement between two of the co-authors. So our results, these are the 4 themes that emerged from the partner interviews. The first was having an expectation of difficulty becoming pregnant. The second theme that emerged was that fertility and fertility preservation conversations are not being initiated by the CF care team. The third theme was that partners desire that fertility and fertility preservation information be discussed and presented from the CF care team. And the fourth and final theme was financial concerns surrounding family planning. So let's delve into these themes a little more. As I mentioned, theme 1 was having an expectation of difficulty becoming pregnant. So when we asked partners if they had ever been told that their partner who has cystic fibrosis would ever have a difficult time getting pregnant, this is what they said. So partner 3 said, I don't know if I'm naturally a pessimist, but at the same time, we knew that this would be a hard time. So getting pregnant is hard, and then keeping the pregnancy is hard as well. And partner number 6 said, I do remember she telling me, she referring to his wife, that she was told that it would be very difficult for her to get pregnant, but that was years ago, probably in her early 20s. The second theme was that fertility and fertility preservation conversations were not being initiated by the care team. So partners were asked if fertility and fertility preservation discussions or content had ever been brought up to them in the clinic visits. And 2 partners had this to say. Partner 18 said, they had plenty of suggestions once my wife was pregnant and after we had baby, but they never said anything ahead of time. And partner 12 said, I haven't been there for an appointment where the CF doctor mentioned it, fertility and pregnancy, without us bringing it up first. The third theme, that partners desire fertility preservation and fertility information from the care team. Partners were asked if they would want to receive this information from their CF healthcare team. Partner 10 said definitely, especially early on. I understand their position, obviously, because it was never something that they were thinking of at the time. It would definitely have helped to have those discussions, find out from the CF team more about those specific types of hurdles that we were going to have to deal with. And he means the specific hurdles when trying to conceive. And partner 9 said, I think it'd be good to ask if we want to talk about it, fertility and fertility preservation, at least. So at least it's introduced in as a concept that they're prepared to discuss. I had 1,000,001 questions when I had my first child, and this is like 1,000,001 times 2. And he's referring to having a child for the first time with someone who has cystic fibrosis as having 1,000,001 times 2 questions. So the fourth and final theme here was financial concerns surrounding family planning. So partners were asked what was the biggest factors that would influence their fertility preservation and fertility decision-making. And partner 9 said the biggest one is really being cost versus the potential for actually being able to conceive. That was something we were thinking about because we were starting to get a little bit doubtful that we could conceive. It would have depended really on mostly financial. And partner 12 said, I don't know, as expensive as that is, when referring to surrogacy or IVF, we would rather spend money on a child in need than go that far, even along the IVF route. So these partners discussed how the financial concerns were a factor that influenced their fertility decisions. So those were the 4 themes that emerged from the thematic analysis with our partner interviews. And overall, broadly, partners to women with cystic fibrosis are essential members of the patient-centered CF healthcare team. Just like patients, partners desire knowledge and support from an honest, open, and comprehensive CF care team. They want to be involved. They have questions. And so for a patient-centered and comprehensive healthcare model, the CF care team should address fertility and fertility preservation early and regularly to improve patient outcomes in healthcare. And here are our references. If you have any questions for me, I'd be happy to take any email. This is my email on the top. Also, Dr. Ladoris' email is at the bottom. As I mentioned, she's the PI of this parent study. Also, one of our co-authors, Ms. Woods, will be here at the end of the presentation to discuss live during the Q&A. Thank you so much.
We would like to thank Jessica for that presentation. And as she mentioned, Brittany Woods will be here for any Q&A. And we do not have any questions in the box yet. But one of the many, I do, Brittany, actually, because one of the many questions that we get a lot from several of our patients is that if there are any resources for, fertility, because since it is such a costly procedure.
Yes, thank you for asking that. At this moment, it's really center specific, because it's really about who your physicians want to work with and their infertility resources within that area. Some people, for some states, surrogacy is legal, and some are not. So that's kind of an issue that some are forced to contend with. But as far as Infertility Resources, I know the website, the Cystic Fibrosis Foundation website, has a few resources talking about reproductive health and infertility. But from the physician standpoint, at this moment, there's really not a lot of resources to be able to give these patients. And that's kind of the problem, is there's no set standards. So as far as being able to actually provide patients with anything, it's really, it's a matter of them being able to advocate for themselves until the physicians can get these resources together. But they really have to kind of, at this point, be their own advocate, which is what we're trying to change. I know that doesn't really answer that question, but that's the problem, is that we're seeing is that there's not these resources available.
Right. They're very limited out there for,
yes,
regardless of whether it's you're doing a MESA procedure, you're doing IVF, or even adoption, yes. Which I can say that for some folks, one of our patients, actually, her work environment actually provides $10,000 if they want to go to the adoption path. And so therefore, what I would suggest is you ask your patients within their work if, if their company has any of those resources available, which was something I had not thought about until she had actually brought that up, which I thought was great for that company to, provide that resource.
Yeah.
We do have a question though. Okay, go ahead.
Yeah, go ahead.
Well, no, go ahead and finish whatever you need to say, and then I'll ask the question.
Well, I was just going to say that there are some, it's very dependent. That's the other thing, is infertility coverage is very dependent on the state as well. Most states at this point, there's only, I think, 19 states at my last check that actually provided any type of infertility coverage. And of those that did, it's not necessarily coverage for IVF. It's coverage for diagnostic testing in some places, and others do cover 1 or 2 rounds of IVF, or it is specific to the company itself. They can opt to choose that regardless of whether the states require it. So that's definitely something else that, when you look back at those financial concerns, that's something else that a lot of people have to contend with, because you have so much financial obligation with cystic fibrosis in and of itself, then to add the issue of having to deal with IVF or any other routes that you choose to take, whether it's adoption or IVF or surrogacy, it's a major financial concern. Did you say you had another question?
I did. Sorry, my little mute button was.
Oh, that's okay.
So the next question is that from Catherine Hinthorn. She says, I always hesitate to give specific numbers for the cost of fertility interventions. She was wondering if you have any specific resources that are available to provide this information. I know that varies from kind of practice to practice, insurance to insurance, and state to state.
It really does. I have seen anywhere between 0 for some places, for just medicated cycles, if your insurance covers your medication, up to $300 a month, simply just for things like Clomid that are, it's a non-monitored cycle. It's just very simple. And I've seen it all the way up to $28,000 a cycle for IVF or ICSI. And it's so dependent on patient need and clinic location and geographic location either, because you have some places that some states are higher than others. So the best advice that I can give is to really just do your research and do your homework. And hopefully we'll get to the point where the clinicians can know at least what's in their area. And that's kind of our goal, is to be able to give the patients those kinds of resources and say, hey, we work consistently with this clinic, or we recommend these clinics, and here's a list of people that can specialize and help patients with cystic fibrosis. And this is the kind of cost that you can expect, because as of right now, that's what a lot of the participants kind of talked about, is that they didn't, not only was it not discussed with them, but they had no idea, nobody could give them a price or a success rate. And those are the kind of things that those patients are desiring. So as much as I would love to give a specific resource that's available, there's not a good one that can really tell you, besides each clinic. If they have a website, they may be able to say how much it costs, but even most websites for clinics are hesitant to say that, because it's so dependent on each person's needs. And like I said, even geographic location. So unfortunately, that's what we're kind of trying to work towards, is being able to give patients those resources, because that's what they would like to have, is they need to know up front, what are our success rates? What are our challenges? What kind of financial issues are we going to be looking at in order to pursue this? Because they need to know that up front, and they feel like people are not really being straightforward with them. And that's completely understandable.
Right. And I can honestly say that just from our clinic standpoint, about specific costs for fertility interventions. So thankfully, I am blessed with patients who are willing to share that information. So some of our patients, and their partners who are actually going through this right now, or have recently gone through it, have shared the cost, whether it just be, that first, MESA procedure, or in the IVF, and then the follow-up of, the eggs that are still frozen because, the first round was not successful. Mm-hmm. So I think that a lot of it is asking your other patients in your clinic what they're doing, and if they're comfortable, letting you know. I wasn't asking how much they had to pay by any means. I was just asking an overall cost, which they were more than willing to share at the time. So therefore, I think that is a beneficial, is just to, use your patients as a resource too. And I we're lucky that we have many patients who are willing to say, hey, if somebody wants to talk about it, let them, reach out to me and I'll talk to them about it too. So, so I think that's a benefit as well, but it is very hard to give an exact number and cost for different things that you're going to do.
Yes, no, absolutely. That's a great point, is definitely to use your patients as your resources too. And I would say, you could reach out to the local infertility clinics and find out if they can give you ranges. They're not going to be able to give you exacts, but they can get you in the price range and say, hey, like a typical IUI cycle costs X amount, whether it's $350 or $500 or $600, or a typical IVF round is this. And and then compile that and be able to actually give it to patients would be something that is fantastic to do. And just say, hey, look, this is what you can expect around here. If you would like to go somewhere else, we can arrange that, but this is what you can expect from at least the clinics within your area.
Correct.
It just kind of helps take some of the burden off of them.
Okay. Another question we have is, have you ever seen the sperm extraction covered by insurance? And it says, I've only seen our patients have to pay out of pocket for this procedure.
That is a great question, Catherine. I have not. Now, granted, there's a lot of different insurance plans, and I'm not saying that it's not covered by any insurance, but from what I have seen at this point, I have not seen it covered. But that would definitely be something very interesting to look into. I'm going to have to keep that in the back of my mind and look into that. But that's a very good question that I wish I had an answer for, Catherine. But no, I have not seen it. But that would be interesting to see, especially compared to maybe the states that do cover IVF procedures and stuff like that, to see whether it is covered in those particular states versus the ones that don't have any IVF coverage. it would be very interesting to kind of find out if that goes in tandem with that. So that will be something I'll have to look into. Thank you for that.
And I can say for our patients a while back, I can say that on the majority, no, I have never seen insurance pay for an extraction, but there was one case where I do not know how the urologist coded it. I don't want to know how the urologist coded it, but apparently he did actually get it covered. So therefore, apparently there are ways to do that.
Yeah. Yeah, I'm going to have to look into that, because that makes me wonder if it's in the states that it is like IVF coverage is higher and more consistent, whether maybe some of those plans would cover that. That's very interesting.
And then we had a response to Catherine. They just wanted to say they're a social worker and actually pregnant spouse of a CF patient. And their sperm extraction was the only thing covered by the insurance. Everything else was out of pocket. It was considered diagnostic. So that may be how the urologist coded it as well.
Yeah, that's very interesting. Yeah, I'm going to have to look into that. That makes me very curious now. I see a rabbit hole coming here.
All right. Do you have any other questions in the Slido, Tiffany?
That's all I see.
All righty. So I think we are ready to move on to our next speaker, who is Emily Siegler, talking about unique challenges of treating women with cystic fibrosis related diabetes in pregnancy. We will go ahead and start that presentation.
Hello, my name is Emily Siegler, and I'm a third-year medical student at California North State College of Medicine. Today, I have the honor to talk to you about a project I've been working on in collaboration with Dr. Marina Litvin at Washington University in St. Louis, and we've been exploring unique challenges in treating cystic fibrosis-related diabetes during pregnancy. We have no relationships to disclose related to this presentation. So as many of you are familiar with, cystic fibrosis is one of the most common autosomal recessive disorders in North America, affecting up to 30,000 Americans today. Of these, almost half of these patients may develop something called cystic fibrosis-related diabetes, which is a unique form of diabetes that combines features of type 1 and type 2 diabetes in its clinical presentation as well as its pathophysiology. It is hypothesized that at a cellular level, the dysfunctional CFTR channels that are characteristic of cystic fibrosis are also found in the pancreatic beta cells that are responsible for producing our insulin. And these dysfunctional channels are thought to play a role in the development of insulin deficiency and subsequent CFRD. Now, hemoglobin A1C is a common lab screening measure used in the general population to pick up diabetes. It is a measurement of the glucose attached to red blood cells in the body over a period of the last 3 to 4 months, and it is pretty sensitive for picking up diabetes, including type 1 and type 2 diabetes. However, in our patients with CFRD, it is actually not very sensitive for detecting their diabetes, even if you lower the threshold, a cutoff for increased sensitivity. And therefore, a different test called the oral glucose tolerance test is recommended for all patients with cystic fibrosis to experience annually, actually, with their providers. The oral glucose tolerance test, or OGTT, is quite cumbersome in nature, so it requires patients to fast overnight, which puts them at risk for low blood glucose or hypoglycemia. And then they come into the office in the morning and are forced to consume 75 grams of carbohydrates, which puts them at risk for hyperglycemia or increased blood glucose. So the test itself is quite cumbersome. It is also has its risks. And finally, patients with cystic fibrosis have many different medical problems they're being managed with. And this is one of those tests that may sometimes slip through the cracks and is not always performed annually in patients. However, it is important to pick up CFRD as soon as it develops in patients. As we know, in retrospect, many patients who develop CFRD in the years leading up to their diagnosis actually experience decreased lung function, nutritional status, and increased rate of hospitalization for infections. Similarly, if patients are not diagnosed with CFRD when they develop it, these parameters tend to deteriorate in them as well, leading up until they receive proper diagnosis and management. Currently, insulin is the only medication approved for treating CFRD. However, we expect to see this expanding as the development of new technologies and therapies emerges. So as nutritional and medical therapies progress and effective drugs become more widely available, such as elexacaftor, tezacaftor, ivacaftor, which is a CFTR triple modulator therapy, better known as Trikafta, we expect to see the life expectancy for our patients to improve, and this will likely lead to an increased prevalence of CFRD. With better nutritional status and this increased life expectancy, it's more likely that patients will attempt and become pregnant. Cystic fibrosis related diabetes during pregnancy, there's not actually a lot of data and studies to have a lot of knowledge background on this unique situation because patients in the past with cystic fibrosis had a hard time becoming pregnant. However, the few studies we do have suggest that there's a higher associated rate of C-section and postpartum complications in these patients. And importantly, there are no current specific guidelines on how to manage CFRD during pregnancy. One of the biggest questions that we have actually is whether strict glycemic targets that are typically utilized in gestational diabetes are, whether these targets are as significant and important for our patients with CFRD for having successful outcomes of their pregnancies. Before I dive more into the cases, I want to kind of clarify some terminology I'll be using. So when we give patients insulin to treat that diabetes, the most common way in which it is delivered is something called basal bolus form. And here you can see we basically try to give insulin to patients in a way that mimics the normal pancreatic function in a patient who does not have diabetes. So throughout the day, a patient who does not have diabetes, their pancreas will release a baseline level of insulin throughout the day, and then will increase the release of insulin when they eat meals at breakfast, lunch, and dinner. And that's represented in this graph by the blood glucose level seen in red. And so once the patient consumes elevated carbohydrates, their body compensates by increasing insulin release, and their blood glucose levels resolve to a normal baseline. So we tend to dose insulin in patients with diabetes by giving them a basal dose that covers a majority of their insulin needs throughout the day, and then supplementing that with extra doses of insulin called boluses that correspond to breakfast, lunch, and dinner. Additionally, sometimes correctional insulin will be given, which is rapid acting correctional insulin that will basically immediately correct any additional deviations in blood glucose that may result from insulin dosing that does not quite match the patient's meal caloric intake at that time. Now, one thing to emphasize is that in patients with type 1, type 2, and gestational diabetes, this regimen tends to be very basal predominant. So over 50% of the patient's insulin typically comes from their baseline dosing, and the mealtime boluses really are just supplemental at that point. However, we've realized in our patients with CFRD that this type of regimen, for several reasons, does not actually achieve as adequate of glycemic control. So with that, we present 6 cases of CFRD gestational diabetes in pregnancy. And this is all from Barnes-Jewish Hospital at WashU in St. Louis. And 2 main points I want to emphasize is, one, our research really focuses on the individualization of patients' treatment regimens and whether they benefited from just nutritional therapy to achieve adequate glycemic control, or whether their treatment required and benefited from insulin pumps and sensor use. And I'll talk a little bit more about that in a minute. The other thing I want to emphasize or kind of explain is that we sometimes use cystic fibrosis related diabetes and gestational diabetes in this presentation interchangeably. And that's because due to the fact that some of our patients did not have regular OGTT screening for CFRD prior to becoming pregnant, during the pregnancy was the first time that patients were actually diagnosed with diabetes. However, it's difficult for us to know whether they may have had underlying CFRD prior to becoming pregnant. Similarly, we also know that pregnancy is an insulin resistant state, and it's possible that these patients actually had predisposition for CFRD or were starting to develop it, but it was really the insulin resistance that came with becoming pregnant that actually pushed them over to developing diabetes. So for that reason, throughout the presentation, CFRD and GDM will be used interchangeably. Our cohort is 6 patients, all with at least one delta 508 mutation, which is the most common cystic fibrosis related genotype. All patients had pancreatic exocrine insufficiency prior to presenting for pregnancy. And some of our patients, as you can see, were diagnosed with CFRD knowingly before pregnancy, while others were only diagnosed once they became pregnant on screening OGTT. I want to take a moment to explain something called hypoglycemia unawareness, which was actually how some of our patients presented, which led to their diagnosis of CFRD. So hypoglycemia basically means low blood glucose. And when patients experience low blood glucose that is not corrected repeatedly, their threshold for detecting this low blood glucose actually decreases. And this can be very dangerous because it can get to the point where patients do not experience autonomic or neurological symptoms with very low blood glucose. And this can result actually in seizures and even coma in these patients if their body's not able to warn them that they really need increased glucose intake. Finally, as I mentioned, the use of diabetes technologies, pumps for insulin delivery or continuous glucose monitors or sensors is what kind of distinguishes our patients within the cohort. And I'll talk a little bit more about that again with the cases. All of our patients had relatively normal pregnancy outcomes and healthy babies, some of whom were induced vaginally and others who delivered by C-section. And this is actually something we're interested in investigating further with our OB colleagues down the line. At this point, would like to bring your attention to patient 3, who I'll be talking about a little bit more in this presentation. The patient had a really unique presentation and outcome of her pregnancy, and that she was brought for C-section due to impending cord collapse at 34 weeks of pregnancy, and actually went immediately after delivering to a lung transplant due to deterioration of her lung function exacerbated by her pregnancy. And that really just stands to the complexity of managing these multiple conditions in patients who have cystic fibrosis, diabetes, and become pregnant. So the patient was a 30-year-old female in her first pregnancy with 1 delta 508 mutation. She had been diagnosed with CFRD 1 year before she became pregnant with this annual screening OGTT. At the time, she was managed with insulin, but she had recurrent hypoglycemia, and she was actually able to achieve adequate glycemic control prior to becoming pregnant with just nutritional therapy alone. So before she became pregnant, she was not on any insulin. However, once she became pregnant, her glycemic control deteriorated. She was out of range quite a bit. So she was restarted on insulin therapy, including this basal dose of 10 units twice daily, as well as a bolus dose of Lispro with meals and correctional sliding scale. This was many doses for the patient to keep up with throughout the day, resulting in insulin injection burden for her multiple snacks and meals. And then the patient also started to notice in herself she was experiencing fasting hypoglycemia and hyperglycemia after she ate meals. When she went to clinic for a pregnancy visit one day during her pregnancy, she was actually found to have a blood glucose of 35, which is very low, but the patient was not experiencing any symptoms of hypoglycemia, suggesting she had developed hypoglycemia unawareness. At that point, the patient was stopped on multiple injections a day of insulin and was given an insulin pump that could deliver insulin throughout the day for the patient without requiring her to inject herself. And she was also started with continuous glucose monitor therapy. So these are readings from the patient's pump and sensor system. And what I would like to bring your attention to is that in a typical type 1 or type 2 diabetes patients or gestational diabetes, we usually expect this percentage here that shows 23% of basal to be over 50%. But for our patient, this was actually a unique benefit of the pump and sensor model, is that she was able to receive 77% of her insulin doses in bolus form, corresponding to her intake of carbohydrates throughout the day. And that resulted in much improved glycemic control with an average glucose of 111 and a pretty tight standard deviation of 37. Additionally, we were able to determine that she was receiving at least an average of 5.4 boluses a day. And so that's 5 or more times a day that the patient did not have to stick herself with a needle during her pregnancy, which definitely had improvements on her quality of life. Overall, her right time in range improved to 81%, and I believe by the end of her pregnancy, this number was closer to 90%. And most importantly, her time at very high hyperglycemia or very low hypoglycemia was 1% or less. This is a reading of her CGM monitor, and you can see her average is represented by the orange line, While she did still have some deviations, some lows and highs in her blood glucose control, overall her management was in range, and that was definitely improved by the pump and sensor technology. So key take-home points. First, pregnancy is an insulin-resistant state that may uncover underlying insulin deficiency in our patients with CF who were previously not diagnosed with diabetes. Second, compared to patients with type 1 and type 2 diabetes, patients with CFRD tend to have a lower basal insulin requirement, or they are at increased risk for fasting hypoglycemia. However, these patients, due to their high carbohydrate diet and multiple meals and snacks per day, really do benefit from rapid acting insulin that can be dosed appropriately throughout the day as they consume meals. Third, patients with CF and diabetes in pregnancy really benefit from diabetes technologies such as these pumps and CGMs to deliver such unique delivery of insulin. These devices can improve glycemic control and communication between physicians and patients, particularly during pregnancy, and have the overall potential to reduce disease burden and improve quality of life. So in the future, we hope to review maternal and fetal outcomes in patients with CFRD versus in patients who have CF who become pregnant but do not develop diabetes. We also hope to see literature exploring the effects of highly effective CFTR modulator therapies on glycemic control, insulin sensitivity, and pregnancy outcomes. Ultimately, we hope that this case series of 6 cases will springboard more research as the number of patients who become pregnant with cystic fibrosis continues to increase. And hopefully, as we acquire more data, this will lead to evidence-based guidelines to help practitioners know how to manage their patients' diabetes in CF pregnancies. Here are my references, and I just want to thank Dr. Marina Litvin and WashU in St. Louis for their support of this project, and the NIDDK Medical Student Research Program, who originally introduced me to Dr. Litvin. Thank you, and I look forward to hopefully discussing this exciting work with many of you at NACFC.
Thank you, Emily, for that presentation. And I encourage anyone to ask any questions in the Slido. So if you have any questions related to this presentation. One of the questions that I do have, Emily, is that when you already know that a patient has CFRD, how quick, I guess how much monitoring and how close are you monitoring what their blood sugars are doing as soon as they are pregnant? I know the OGTT is usually not done with those who we do not know who have CFRD prior to, it's done later in the first trimester. Is there a suggestion to possibly check that earlier?
Yes, thank you so much for that question. So as I mentioned, the OGTT, while it may not be necessarily first priority for a lot of our patients because they have so many different management complications with lung function and nutritional sufficiency, but it is something that is recommended, I think, by the ADA and the CFF to occur annually in patients, even those not considering pregnancy. And so I think the idea is to pick it up early, right? Because as I mentioned, there's lots of complications that in these patients, when we look retrospectively, that were occurring related to their diabetes that were not being addressed because it hadn't been picked up. So I think it is important to try as much as we can to comply with the screening OGTT, and that will probably be done by the patient's primary CF provider. And so that would be in an ideal world. However, I know at many centers, the annual screening OGTT is occurring maybe 50% of the time for patients. So if it's picked up before pregnancy, that's ideal. Otherwise, I think a lot of our patients were not necessarily actually diagnosed with their gestational diabetes, if that's the first time they were diagnosed, until second trimester when they undergo regular OGTT screening. But I think if they have, if a patient has not been regularly screened for OGTT in the last year and they do become pregnant, it would be a good idea to screen them upon initial presentation for pregnancy, just because it's another reason that there's a paucity in the data correlating this in this particular patient population. But we know in general in pregnancy, poor glucose control is associated with poor maternal and fetal birth outcomes.
Thank you. And I know that we have actually ordered an OGTT on a couple of our patients prior to the actual OB ordering it, because the patient themselves said, hey, I want to check it sooner than later. So therefore, we actually ordered it ourselves. We do have a question, and it comes from Rachel Bertelli. She's asking for the patient in case number 3. How was the initial dose insulin dose determined, and what was her initial weight-based dose?
So I can definitely look into that information in terms of the initial. I don't have it on hand, but I think her initial dosing was probably a 2/3 bolus, 2/3 basal, 1/3 bolus. And then it was adjusted accordingly as as there was shown to be improved glycemic control with a heavier bolus dosing. And yeah, I can definitely look into more of that information. These were my my mentor's patients, and so I'd have to go back and look in the EMR.
Okay. And then another question related to case number 3 is from Danielle Gardner. She said, we had a very similar situation at our center, and a female with diet-controlled CFRD who needed insulin therapy during her pregnancy and then had a cord collapse at 39 weeks. Do you have any predictions as to why this may have happened in your case number 3?
Yeah, so that's really interesting to hear that there was a very similar situation. I would need to check back in the EMR to see what happened in her course. So I'm sorry, I can't give you an accurate answer on that right now. However, I would say it's just very interesting to me to see that patients are on optimal nutritional therapy until they get pregnant, and then the insulin resistance and perhaps the stress of the pregnancy on the body makes it so their glycemic control is less adequate. And in this particular patient, I know that the lung function deterioration was severe and required her to undergo that lung transplant. And this was actually related to one of the previous questions earlier in the session. This was a patient who was on Trikafta and was she was on Trikafta in part of a clinical trial. And then because she was not intended to get pregnant, this was kind of probably very early 2020, end of 2019, she was forced to stop Trikafta, and then she had this very serious lung complication. And so this was an M&M conference at WashU based on that sequence of events, which was really interesting and brought up a lot of ethical questions.
Thank you. Also, for case number 3, you mentioned that she was taken straight from delivery for a lung transplant due to her deterioration of the lungs. How were you able to get a match so quickly? I feel like our patients are always waiting such a long time.
Yeah, again, I'm so sorry. I don't have better answers to this. This is something my mentor and I have been kind of working on together with. And so I can definitely take note of these questions and get you some answers by talking to her afterwards.
Okay. We also have another question for you, and this is from Lauren. She says, their high-risk OB has suggested that we obtain the OGTT as soon as the patient becomes pregnant, as this would assist us in diagnosing the underlying CFRD unrelated to pregnancy. And is this something that maybe we should all be considering?
Yeah, that's a really good question. And that was kind of related to what you had asked initially, Jana. I mean, so again, the disclaimer being I'm a medical student, I'm not yet in practice, but I think that to me makes sense because the guideline management is to have an OGTT annually. And so if the patient for whatever reason hasn't had that in the last year and they become pregnant, because we know the complications diabetes poses in pregnancy to outcome, an OGTT upon presenting to pregnancy sounds very reasonable to me. And it reassures me that your high-risk OB also thinks similarly.
All right. Are there any more questions for Emily at this time? I don't think we have any more in this one. All right. So, and if you think of any questions, please, at the end when we're all joined together, please ask those at that time and we will certainly address them. So we will move on now to an anticipated talk, as we had a question about it earlier. What were those outcomes? So this Andrea Lavoie is actually a mother with CF, and her talk is My Pregnancy Experience, A Mother's Viewpoint. So we will switch to Andrea, please.
Hi, my name is Andrea LaFoy. I'm 35 with cystic fibrosis. Today, I'm here to talk to you about my pregnancy on Trikafta. Before I start that, I figured I'd give you some backstory on how I was before Trikafta. In 2018, I started getting pretty sick, just slowly deteriorating. At one point, my lung function was in the high 20s, low 30s. So they sent me over to Baptist here in Oklahoma City to see about starting the process for a lung transplant. And while we were doing some of the workups for that, we found out I was in heart failure, which meant that we could no longer just do a lung transplant. I had to have a double lung heart transplant. It was a huge shock. We could not believe, that was a big part of the issue. So we actually got sent here to Stanford in Northern California and did the evaluation for a double lung and heart transplant. I got listed about a month after that. And I was listed for several months. I was on oxygen 24/7. Slowly, with a lot of work put into it, I started doing a bit better. And I did well enough to get off the transplant list. And then December 19th, 2019, I took my first dose of Trikafta. The difference was pretty quick. And, within a couple of weeks, I was hardly coughing. It was amazing to come from being transplant, candidate to off oxygen, feeling better. And then to my surprise, February 28th, we found out that I was pregnant of 2020. I was completely shocked and really scared, but excited. And both of my teams here and there, both suggested I not follow through with the pregnancy because obviously it was very dangerous and it could kill both me and the baby. But I had faith that things were going to work out after a lot of, thought and concern. We decided to go ahead and keep going. And I'm just so grateful I did. At 20 weeks, they said she was measuring small, like her abdomen was in the first percentile. So that was obviously a concern, but they said, let's just see how things go. And by the 24th week, we did an echo on her heart. Everything looked great there, but she was still very small. So we just, at 24 weeks, they said, let's try to get to 28 weeks. If we can get to 28 weeks, let's try to get to 32 and then try to get to 34. And then hopefully we can get you all the way to 37. So we just, I had a lot of appointments. I was there every week to every other week. She still continued to measure small. At my appointment at 31 weeks, I was admitted into the hospital because the cord blood flow was not looking very good. It was flowing backwards in some spots. It was stopped in some spots. So they admitted me. She was monitored 24/7 for like 2 or 3 days. I got the steroid shots to boost up her lungs in case she had to be delivered. The steroid shots helped quite a bit. The cord blood flow was doing like it should. So I was able to go home after a few days. And they said, we'll just keep monitoring everything and seeing how things look. And they told me from there on out, we need to have a bag packed anytime we come up there because I could be admitted anytime. So we went up at 33 weeks and 2 days. I had an appointment and the cord blood flow was not looking very well again. So they said, we're going to admit you. You're going to stay here until you deliver. So, I was thinking I'm going to be there like 4-ish weeks, but okay, we do what we need to do. And September 11th, which was 33 weeks, 4 days, they came and said, we're going to let you go home as long as your echo looks okay. Not echo, I'm sorry, ultrasound looks okay. Then we'll send you home. And then we know you'll come back up if there's any problems. As they're doing the ultrasound, I see them checking multiple spots and thought to myself, I'm probably not going home. So they come and they said, well, we're going to deliver on this evening. They would have said this morning, but I had already eaten breakfast. So they said, well, wait till this evening. They wanted me in an ICU bed afterwards just to be safe with my heart and, everything. So then they changed it to, we're going to deliver you tomorrow morning, which is Saturday, September 12th. So I called my mother and I called my husband and I said, okay, we're having a baby tomorrow morning. So my husband came up and stayed that night. We had a C-section at 9:21. Saturday, September 12th. She was 2 pounds, 15 ounces, 15 inches long. So she was definitely tiny. And she went straight to NICU. I went to ICU for 24 hours where everything went well. And now, this is the first time I got to see her. She is, like I said, a little tiny thing, but you would have no idea that she was a preemie baby. She is such a big girl now. I'm so grateful for her. I posted pictures, each month of how far she's come. And she did well. She was in NICU for 5 weeks and then got to come home weighing just under 5 pounds. And I stayed in the hospital for a few days. And then I came home. And so we were up there every day to see her in the NICU. Thankfully, we live close enough to the hospital to be able to do so. She is now 1 year old. She's so big and she's so strong. None of this would have been possible without Trikafta. Without Trikafta, I would have never been able to get pregnant, much less have a healthy baby. She is literally the light of our life. And I just could not be more grateful to Trikafta for allowing me to feel well enough to chase after her every day. And, just for my miracle, Riley Grace. My lung function in the beginning of my pregnancy was about 45 to 48. Now it's all the way up to 61. And that really is all thanks to Trikafta. So I, once again, just could not be any more grateful for the experience. And here's my perfect girl I'm sharing with you guys. Thank you so much.
Thank you, Andrea, for that presentation. Your daughter is adorable. Do we have any questions for Andrea at this time? A couple of my questions I had, she actually answered in the end, which was about what her lung function was at the beginning of the pregnancy and then what it is now. So it's wonderful that you're now up to 61%. That's great.
Thank you.
So if we do not have any questions, or if you think of something that you would like to ask Andrea, I think we're going to go ahead and have all of the presenters together. So therefore, if there are any questions for any of them, please, put those in the chat box and we will get to those. I did want to go back to Dr. Monemeyer though, and ask, because she had followed up on the potential complications for those patients that she discussed. Is Dr. Monemeyer still with us?
Yes, I'm here.
Okay.
Thank you. Yes, I just wanted to follow up on the prior question regarding the 2 potential complications in the CFTR modulator international survey, and both were. It was unclear. The authors were unclear if they were directly related to lumacaftor ivacaftor, but the 2 potential complications were, one was a pulmonary exacerbation, so they weren't sure if that was just from prior the patient's history of her CF lung disease, and then the second one was a new diagnosis of AML, or acute myeloid leukemia, but both were thought, as I said, to be unclear to the authors. And I guess in my personal experience, I have not seen any type of new malignancy associated with any type of modulator therapy. So I just wanted to make sure I followed up on that question.
Okay.
And then if I have a minute, I just wanted to ask Andrea a follow-up question that I got earlier. Well, one, thank you for sharing your story. And I know someone in the audience brought up earlier regarding lung function and breastfeeding, and you mentioned yours was kind of in the severe to moderate range of lung function. Can you share if you did breastfeeding after delivery, or if you got any specific recommendations on breastfeeding given your lung function?
I did pump for about 3 weeks.
Okay.
They told me, my heart doctor told me it would be best to stop because I needed to get back on my heart medication. Otherwise, I would have definitely done for longer. I really wanted to, but.
Great. Thank you so much.
And Andrea, we do have a question for you. Do you still follow with transplant, like on a yearly basis, or?
I do telemedicine with transplant every 6 months. They just want to keep following just in case something was to change, or, just so they know what's going on.
Okay. And we have several comments as far as thank you for sharing your story. So it's always great to hear from a patient and to have a patient perspective of everything that's going on. So let me see here. Sorry, I'm going down through the questions to get to the next one. And this is a question. How did your pregnancy affect your cardiac function during your pregnancy?
It actually just stayed the same the whole pregnancy. It's still the same as it was before I got pregnant now.
Okay. And then I think this might be a question for the entire panel. Are there any thoughts or evidence on babies of CF moms testing negative on newborn screening due to mom being on Trikafta? And I'm going to put it out there because, yes, I heard this the other day. So it's kind of funny that you asked this question, is that apparently we are getting some negative IRTs. And what the guidelines are going to be as far as how soon you recheck an infant, I'm not really for certain on that yet, but I do know that there have been some cases where there have been some negative IRTs with the moms on Trikafta. So it'll be interesting to see how these modulators are affecting, how we're diagnosing the newborns. So with that, there's also another question, and this is for probably focused more towards Emily. Is it most likely that a patient with CFRD will likely develop gestational diabetes?
Yeah, I saw that one. Great question. I kind of went into that terminology. Some of our patients, we don't know whether to consider their diabetes gestational or CF related because it pops up during pregnancy. And if they weren't being screened with OGTT, we don't know if they had it previously. In terms of being able to tease the two out. So right now, I think for our manuscript, we kind of lumped them together because we didn't have a good way of teasing them out. But one thing I wanted to bring up was the Mayflower study, which I'm sure many of us are very excited about. And I've had many discussions with my PI about how hopefully we'll be able to kind of get more stratified data from that study. We hope they'll be asking patients about, gestational diabetes and so forth. But I think patients who have CFRD and are diagnosed with that before they become pregnant, if they are already on insulin therapy, then that is, while we know that the pregnancy can exacerbate their glycemic control, if they're being closely monitored, it doesn't necessarily have to result in like a recurrence of their diabetes being outside the glycemic range during their pregnancy. But again, that's also a really great benefit of the pump and sensor system, is that you can so closely monitor their levels during pregnancy and adjust accordingly in like lifetime. Thanks for the question.
Thank you. And we do have a couple more questions for Andrea. The first one is, Andrea, do you ever mentor other mothers who are pregnant, women with CF throughout their journey? And your story brought tears to their eyes, and I thank you because you are so inspiring.
Well, thank you. There is a couple of Facebook groups that I'm a part of, moms with cystic fibrosis and also Trikafta moms. So I do like contribute to those, but I don't really necessarily mentor anybody.
Okay. And they're also asking, do you think that you're doing more airway clearance in your therapies as you have started Trikafta and motivation seem to be better?
I have actually always been really good about doing all of my airway clearance and treatments. So I do everything the same that I did before. I know a lot of people have decided to stop doing treatments because they feel good with Trikafta, but I don't do that. I still keep up with everything.
Okay. And from Carolyn Wheeler, she says that they have a family that is pregnant, and the mother recently found out that she was a CF carrier, and so was her husband. They're asking, this is for the panel, would the baby possibly benefit from Trikafta if the amnio shows that he or she has CF? Any thoughts on that from the panel? And I'm not really for certain on how, whether this is a thought, if the mother took the Trikafta, would that be a benefit? But getting that approved through insurance would probably be a nightmare in and of itself. But I think that is something that, obviously has not been looked at. So therefore trying to answer that is very difficult. But obviously, if the baby does have CF, getting, hopefully approval for Trikafta continues to go down in the age, and that we can get them started on that as soon as possible. Anybody else have any thoughts on that particular question?
I mean, I was just going to say something similar to you. So kind of disagree, agree with your comment from that.
Okay. And also for the panel from Shelley Webb today, what have we found is the best way to test a partner's genetics before pregnancy? She writes, I found that our high-risk OB only does it after the patient is pregnant. Our pulmonary clinic won't cover it for partners, and our provider is unsure if primary care providers can order a specific genetic test.
And I can answer just kind of from what our center does, and it may be, I know it may be different kind of across different centers, but we haven't had any issues having our, like I said earlier, most of our patients will get just the standard genetic screening test ordered through their PCP. I haven't heard issues though about it being covered by insurance, but I would think it would, given that their partner has known CF, it would be important to know that. So we've been going through this partner's primary care physicians, and then as well as referring to genetics at our center again if needed. But definitely would be important to know, and I'd be surprised if it wouldn't be covered.
In our center, I agree with you, is that if we're talking pregnancy and we're doing pre-planning pregnancy, of course, that is what we're always suggesting as well, is to offer, let's send you to genetics. So therefore some of this can be discussed. And obviously, they tend to get insurance to pay for it because of the mere fact of that, yes, the partner has CF. And so therefore this is the reasoning behind all of it. But we definitely try to get folks to the genetic counselors prior to the pregnancy. So therefore, then, the couple themselves are better prepared for what's gonna come too. Because if both are carriers, obviously one has CF, the other, if they're a carrier, then that's their decision to make. Do they want to, continue with trying to get pregnant with the possibility of having a child with CF, or do they want to seek other avenues with adoption or something else in order to have a child? So I think it just helps provide the couple with a better, education and resources as well. We do have, okay.
I was going to kind of go off of that. Yeah. So first of all, I was going to mention that when I worked prior to medical school in just the OBGYN clinic, the Natera or genetic screening was common for even patients without CF to do a comprehensive panel that includes the CFTR gene screening for both members of the couple. I actually wanted to ask Dr. Montemayor, for that couple, you had mentioned that they're getting married and getting interested. Like, do you think it's too early to do the screening now, or would there be any utility to waiting until they're closer to trying to conceive, or one less thing to do if they do it now, I guess?
Yeah, I mean, and I think the status and the carrier status is not going to change, whether it's done now versus in 2 years when they're planning. That's a variable that will be what it is if it's shown now or not. And I think just talking, and I think there may be some additional questions about, our patient who's on Trikafta has great lung function, is her BMI is increasing, her chances of becoming pregnant if she's not, taking any type of contraception may be slightly normal than what we have thought previously. So I would think knowing ahead of time and knowing as soon as possible would be best for both of them as far as planning purposes go.
And along that lines, Rebecca Dara says that for testing partners for carrier risk, she strongly recommends referring to the genetic counselor because they'll be able to order the most comprehensive testing that is actually needed with that. And then one of the other questions we have is, does Trikafta increase your chances of pregnancy to normal or more than that of a patient who does not have CF? My thoughts on that, I don't think it increases it more than someone who does not have CF. I think obviously we have Trikafta babies. I think, a lot of centers, that's what we're calling them. And so, yes, does it increase your chances of pregnancy to normal? I think so. Where the more comes in, yes, someone who's not on a modulator or Trikafta itself, those who are on Trikafta are, yes, more likely to become pregnant if that's the so desire than someone who is not with CF. Anyone else have any other thoughts on that?
I would say from our center, perhaps just a thought change for folks that had an idea like when it's time for me to start a family, it's probably going to require some effort, and changing that mindset to I'm on Trikafta now. I need to be thinking about preventing unintended pregnancy, and I need to be thinking about family planning much earlier rather than thinking what might I have to do to achieve pregnancy, but what do I do to plan my pregnancy at an appropriate time that I desire. So I think a lot of it really is a mind shift for our patients that thought, when the time comes, if I decide that I want to start a family, I might have to put effort into it, and that just mind change of, I might accidentally get pregnant if I don't do something about it ahead of time. So that was kind of what we were trying to educate our patients on. Don't have this idea that might be hard to achieve, because we've seen it happen.
I think additionally, just considering that not only is a patient more likely to become pregnant, but they probably also have an increased successful pregnancy outcome, getting to closer to full term based on the improved physiology that comes with being on Trikafta, which is really exciting to hear from all of you in your experience as well.
Yes, and I think you also have to have the talk with the patients who have for years and years been told, or they have, never been on contraception because, it's been this long and I've never gotten pregnant. And so therefore it's having the conversation with all your patients who are not on contraception saying, hey, you know what, you're on Trikafta now. And this is a good possibility that it could actually happen now that you are taking this medication. So, and just, patient to patient, one-on-one, and talking with them, of course. We have about 15 minutes left, but do we have any more questions for any of the panel? If we do not, we will just wrap up early, but I appreciate everyone watching this session and participating, asking the questions, and getting some of those answers that probably others of us were thinking, and we just, you hadn't asked. I do have a comment here. In females, unless FEV1 is very low, thick cervical mucus was an issue, which may now be thinner and close to normal cervical mucus. And then the other comment is, Andrea, your commitment to CF care may motivate lots of patients who struggle. Would you be okay if we request you to mentor some of our young teenagers?
Sure, that would be fine.
And I just wanted to kind of comment on the comment made about, thinner cervical mucus. And I think there have definitely been some studies within CF with highly effective modulator therapies that fertility overall has been reported to increase. One of the effects definitely is the beneficial effect of cervical mucus thinning, as well as normalization of bicarb secretion in both the uterus and the fallopian tubes. So I think that kind of goes back to the previous question. You're not more pregnant than someone with a non-CF person, but you're going to be equivalent to a non-CF person with the regards of getting pregnant.
Thank you. And then also we have a comment that says Ambry can send the primary care a test to be done. Ambry can also do a pre-insurance verification to see if the insurance covers it and how much will be covered. I'm good with the genetic testing. So that's a nice resource. Thank you. Do we have any other comments or questions? Well, thank you again to everyone. Thank all of our speakers for presenting with us today. And well, we do have another comment that says, remember the Academy of OB requires only 40 CF mutations. So I thank you for coming and participating in the session, and I hope everyone has a great conference.